So simply reducing the work on the heart gets better. The excess blood volume can get better. High blood pressure can get better. Insulin resistance can improve. Fatty liver disease can improve. So lots of risk factors go away. Whether we can actually reverse the changes that have occurred in the heart over time is less clear. That's a topic of a lot of discussion today. But I would argue that it almost doesn't matter.
Greetings, everyone. Today I have a fantastic guest with us, Dr. Sheldon Litwin. Dr. Sheldon Litwin and I go a long way. I've known him for more than 10 years of our lives right now, I think. Dr. Litwin is a renowned cardiologist. He's a professor of medicine. He finished his training at the Washington University School of Medicine, residency in University of Arizona, and completed a cardiology fellowship in Beth Israel, Harvard Medical School. He is here because he has very specific interests, which aligns with me also, which is obesity, heart failure with preserved ejection fraction, and also focuses a big deal on exercise and weight loss for prevention and treatment of cardiovascular disease. He is also an avid outdoorsman and an exercise advocate. He is passionate about exercise in all different levels. He shows pictures of his 80-year-old friends with double hip transplant replacements, hiking, and he is truly a pioneer in this field and is an inspiration to all of us. And there's a lot all of us, including I, could learn from Dr. Litwin. Without any further delay, Dr. Litwin, welcome to Reboot with Dr. Arasi Maran. How are you doing today?
I'm doing great. Thank you so much for the invitation to talk to your audience.
All right, Sheldon, can you tell me what brought you to this place? Like, how did this interest in obesity and exercise, how did it come along?
Well, it's kind of a long story. I think really my interest in cardiology probably stemmed from my lifelong goal of being athletic and my interest in sports and my passion for that. And so I always had been interested in how the heart was involved in our ability to exercise. And I think that was initially really what made me choose to become a cardiologist. And then, of course, that's evolved over time. And I spend more time exercising now than I ever did in my life, partly because of trying to fight off the ravages of age and stay fit and keep up with my younger buddies. But more and more, I'm convinced that it's the key to longevity. It's the thing that we control more than anything else that I think we can do to keep our lives sane in the modern world and to stay healthy.
Fantastic. Sheldon, let's start this conversation a little bit more on your specific interest, right? Which is heart failure with preserved ejection fraction. It's not very well known. When people think of heart failure, they think heart attack and the heart is not functioning well, but this is more common. Can you talk a little bit more about that and explain why that happens to us?
Yeah, so it's first thing I tell my patients is it's a big mouthful. Most people can't say the words heart failure with preserved ejection fraction, and even if they could say it, they don't know what it means. So it's a disease that we are seeing increasingly today, and as you mentioned, it's the dominant form of heart failure. Now, I don't like the term heart failure. It implies that the heart is failing to pump properly, and that is not the case in this particular disorder. So I tell most of my patients, we abbreviate it, by the way, HF-PEF, heart failure with preserved ejection fraction, and most cardiologists now use that terminology. I tell my patients just to call it HF-PUF because the cardinal symptom of this disease is shortness of breath with exertion. And so most people can remember that, and it sort of strikes a chord with them, and they say, "Oh yeah, I kind of get it now." So,
and they are huffing and puffing with
yeah,
this.
if you come in and tell us that you have huff puff, we'll all know what you mean, and you don't have to remember the terms that underlie it or know what an ejection fraction is or any of that stuff. But the ejection fraction is the percent of blood that's pumped out of the heart during each heartbeat. And there's one form of heart failure where that's reduced, and typically that is due to heart attacks or other conditions. Whereas what we're seeing today is where the heart can pump normally, but it's failing to fill with blood adequately. And in order to increase the blood flow to exercising muscle, the heart has to not only be able to pump more, it has to be able to fill more. If it can't fill, then it can't pump. And so the failure to fill is really the heart failure part of it. But it's a whole different set of mechanisms that causes that. And so this failure, we believe, is due in large part to stiffening of the heart muscle. And that stiffening is something that happens in other parts of our body. It's part of normal aging. So we lose elastic tissues and we gain fibrous tissues as we age. And that's why it becomes hard to touch our toes when we get older. It's why we have to wear reading glasses, because the lenses of our eyes stiffen. It's why our skin doesn't look nice anymore like it did when we were young, because our skin stiffens. It's why our blood pressure goes up, because the blood vessels stiffen. So it happens everywhere. But wearing reading glasses is okay, whereas not being able. So, but that's the sort of fundamental problem. And then there are things that accelerate that process. And most importantly today is obesity tends to be the driver of that. But the metabolic complications that come with obesity, such as diabetes or insulin resistance, non-alcoholic fatty liver disease, sleep apnea, high blood pressure. There's a whole host of things that accompany overweight and obesity that cause the heart to become more stiff faster at younger ages. And so, once this was considered a disease almost entirely of aging, today we're seeing this often in younger people, and in that subset, it's driven almost entirely by the obesity epidemic. So, that sort of, for me, that's what I focus on clinically is HF-PEF, and the treatments then sort of come back to lifestyle in large part. Is one of the things we can do is talking about weight management and exercise. And just again, obesity is one of the drivers. Other people have said that this is really a disease of exercise deficiency. And so really, the two things go hand in hand, I think, as we all know. Exercise is not a great way to lose weight. You have to exercise a lot, but in conjunction with dietary modifications, then the two things are complementary. So most weight tends to be lost by caloric restriction, but weight maintenance comes through exercise over the long term. So we need both things.
So correct me if I'm wrong, in the past, I remember when I started training, this HF-PEF was thought to be a disease of elderly, extremely thin female patients.
Yes.
And over the past several years, it's basically made a paradigm shift, and the age group has lessened, and obesity has become a big driver of this disease.
That's correct. And people like to talk about what we call phenotypes of HF-PEF, meaning the type of patient that gets it. It may also refer to the underlying conditions that cause it. And it's pretty clear there still is a group of elderly people that have longstanding hypertension that get this. And interestingly enough, it continues to be a female predominant disease.
Mm-hmm.
In almost all the trials, more than half the patients are women, which is very unusual for basically every other form of heart disease is male dominant. And when you look at the clinical trials, 75% of people in the coronary trials, the MI trials, the AFib trials, they're all men. But in this particular disease, it's more women than men. And whether women are particularly susceptible or whether they just get it as commonly as men, but they don't get the other forms of heart failure because they only have half the prevalence of coronary disease, we don't know. But it's an equalizer, I guess. It's one of the few areas where all the clinical trials, we actually have more women than men. So
no, we want more women in clinical trials, but I think we could have taken a pass on this one.
Yeah, exactly. So it's not exactly a great benefit. And it may also play into this that the rates of obesity, and especially severe obesity, are higher in women than they are in men, and particularly in sort of underprivileged groups of women, African Americans, Hispanic Latinos, Native Americans, where the rates of obesity are really, really high.
So, let's say we have an obese patient, a young, maybe in their mid 40s or 50s, okay, and they are morbidly obese. If they reverse their obesity, if they come into, what we call normal BMI, does the process reverse itself?
So it's a good question. A couple of things I want to say about that. One is we are trying to get rid of the term morbid obesity.
Mhm.
So all of the medical societies, the American Medical Association, the American Heart Association, the Diabetes Association, the Endocrine Society, have all said that obesity is a disease. It's no longer considered a personal failure. We all know lots and lots of patients and friends and family members who struggle greatly with this disease, despite the fact that they try to exercise regularly, despite the fact that they do not have terrible diets. And, we don't know exactly why that is. There clearly are changes in our metabolism as we age, but there seems to be other things at the societal level. The prevalence of significant obesity has tripled in the last few decades, and uh, there's a lot of other things that haven't changed very much. Our genetic stock hasn't changed. So in any case, that term, I really, really don't like to use it, and in fact, I don't ever use it. We don't use that kind of terminology really for any other disease that somebody's got poorly controlled diabetes or poorly controlled hypertension or poorly controlled lipids. We don't ascribe any blame to the patient and use terminology like that. It's a disease that they have and we manage it. So that's sort of point one. Um, about whether it's reversible or not. And the answer is everything suggests that it is, at least to some extent. So there are two things that probably happen with obesity related HF-PEF. So one is that as body size increases and fat mass increases, the heart has to pump more blood because there's more body. So that results in a state of sort of chronic overload of the heart. It's like you're walking up a sandy hill and you're losing a little bit of ground with every step you take, and it's much harder to do. And over time, that causes the heart to enlarge, the walls to get thicker, and causes some damage. So when you reverse obesity, that increased demand on the heart goes away. It's as if you were walking and carrying bags of groceries. It's much harder. If you set down the bags of groceries, it's a lot easier. So simply reducing the work on the heart gets better. The excess blood volume can get better. High blood pressure can get better. Insulin resistance can improve. Fatty liver disease can improve. So lots of risk factors go away. Whether we can actually reverse the changes that have occurred in the heart over time is less clear. That's a topic of a lot of discussion today. But I would argue that it almost doesn't matter. If we can make people feel better and make it easy, even if their heart is still impaired, if it's easier for them to do the things they need to do because they're carrying less excess weight, that's a win.
Yeah.
And if we can potentially get people off other drugs because their blood pressure is better, their diabetes is better or gone, their sleep apnea, again, may improve or maybe even get rid of it. The diabetes definitely can be cured. So all these comorbidities can go away. People can stop taking so many pills, which most people hate doing. They can feel better. And again, whether there's fundamental structural changes in the heart or not, almost doesn't matter in my opinion. And some people argue about this, but I would say, who cares what the mechanism is as long as people feel better.
One of the biggest reasons, I've started this podcast is I feel sometimes when our patients come to us, it's a little too late. They come to us by the time they go to the primary care physician and get a referral to a heart cardiologist, it's a little too late. We almost feel like we need to catch them much earlier in their lives. And how do we incorporate this? Is this just education in the high school level or college level, or where can we send this message out louder and clearer?
Well, that's a really, really good question and a really hard one to answer because everybody in the world knows that this is a problem, right? There is not one person in this country that is not aware of this as being an issue. Obviously, physicians, but lay people, everyone knows this. And there's been a ton of hand wringing about it, and there's been lots and lots of discussion, and lots of stuff has been tried. And so far, it's been largely ineffective. Despite the recognition of this being a problem, and people saying, well, it's because, it starts in childhood and they eat unhealthy food and they're no longer exercise and they sit and play on their phones all day. And all these things are true. And yet most of the interventions that have been attempted thus far, increasing playtime at school or trying to get kids to eat healthier diets or whatever, haven't really worked for whatever reason. It's probably it's just the sort of pervasive changes in our society today. The prevalence of obesity has continued to go up, even in very recent years, and it's true in pretty much every sector of society. A little bit less perhaps in more affluent people and people with higher levels of education, but it's not just the United States, it's around the world today. And we're seeing it in, countries that don't have the resources that we have, and obesity rates are rising there. So it's a very, very vexing issue. And I wish it was as simple as saying, let's go back to an agrarian lifestyle or something. And, kids need to go out and do chores on the farm and get up in the morning and walk to school and, take a little bag of lunch with them and not eat at McDonald's. And, maybe that would work, but those things probably aren't going to happen. So yes, we need to get the message out, but the reality is that for us to actually dent this problem, it's going to take more than that, unfortunately.
And, I always wonder about the timing of treating obesity, and you're absolutely right. There's so much shame associated with obesity. Recently, I had a person interaction where this person really wanted a GLP-1 because their weight is more than 200 pounds, etc. And the way they went around and around and eventually broke down into tears before kind of bringing up the courage to talk to me about it. I mean, I was like, then I literally had to say, you don't feel ashamed of yourself because you have high blood pressure. This is a similar problem. You don't need to be ashamed of this and, and literally feel so embarrassed about it. I think there's just so much shame associated with it. And because of that, and there's maybe a level of discomfort also maybe for physicians to bring it up with the patients. And I just feel like we don't talk about it sooner with our patients, or we don't offer treatment for obesity per se. And now there's a lot going on for the treatment of obesity. What are your thoughts about the drug therapies we have now?
So it's an interesting conversation to have. First of all, I would say I am completely convinced that we as a healthcare profession have entirely failed in dealing with this. And I've been preaching this for years. And it was striking to me how often I would go give a talk about obesity management and pharmacologic options and bariatric surgery. And I would hear from cardiologists all over the country that say, I had no idea that there were any medications that were effective. Now, of course, today, everybody knows because it's all over the place. But the conversation has perhaps changed in not all good ways. So we have things to offer, but we had started to reach a point where I think people were talking about, different body sizes, different body shapes, as being something that we're all different. And again, it's not necessarily something to be ashamed of. And the sudden advent of these drugs now is sort of pushing it back to where things were before, where, now everybody feels that body image and thinness and whatever it is that's perceived as beauty in this country is sort of going back the other way. So there's not all good. But on the other hand, these drugs now are very effective. They seem to be very safe, and in fact, actually have cardiovascular protective effects that may be independent of the weight loss that's associated with them.
Just to be clear, we're talking about the GLP-1 agonist right now, the Trulicity, Ozempic, et cetera, right? Just so we're on the same.
Correct. So, and of course, we about this more, but there's evolution of these drugs to affect other hormones that come from the gut that seem to be related in metabolism and appetite regulation and so forth. But yes, those are the most effective. Now, I want to throw in a pitch that I'm still a big believer in some of the older drugs that have been out there for 50 years that are perhaps not quite as effective, but are generic drugs that are inexpensive. And the problem with the new drugs, the GLP-1 agonists, is that they're extremely expensive and hard to get. And
Are you
so
talking about metformin when you say generic medications?
metformin is a very weak weight loss medication that sort of classically people lose a couple of pounds when they start taking it, but that's about it. And for most of our patients, that's really a drop in the bucket. But no, I'm talking about phentermine and topiramate largely. So, phentermine has been given for 50 years. It has a bad rap because it was associated with the fen-phen debacle that happened in the 80s and 90s. And so that was a combination of phentermine and fenfluramine. And the combination, the fenfluramine got pulled off the market because it caused pulmonary hypertension and valve disease. But the reason that millions of people were prescribed these drugs is because they worked. And so it was the notion that we have multiple appetite regulatory pathways in our brain that make us want to eat, because eating is a survival mechanism. If people don't eat, then they don't live. And so if you block one appetite pathway, there are many, many others that can compensate for it. So they had this idea that you block two different appetite pathways with two different drugs and get synergistic effects. And that was the case with fen-phen. And it's still the case now where it has sort of been recombined. So phentermine along no longer fenfluramine, but now given with topiramate or Topamax, which is a drug that was commonly used for migraines, seizures, other things, but it has central brain effects, and appetite suppression is one of them. So giving low doses of phentermine and topiramate in the Conquer trial was associated with 13% body weight loss. And I would just point out that when you look at the trials with semaglutide, also known as Ozempic or Wegovy, in healthy volunteers, they get about 15% weight loss. So there's really very little difference, but the semaglutide goes for $1,300 a month, and phentermine topiramate generic is about $10 a month, even without insurance coverage. So, if you talk about dollars per pound loss or sustainability and long-term cost effectiveness, phentermine topiramate is great. So I use it a lot still, and especially for people who can't get the older drugs. And I would just say, cardiologists are very afraid of phentermine because it's a mild stimulant, and there's a concern that it could raise blood pressure, increase heart rate. The reality is that those things don't happen, and that if people lose weight, their blood pressure actually goes down while they take phentermine. And the increase in heart rate in most of the trials was only about 1.5 beats per minute, which is almost nothing. And it's actually the same as what's been seen with the GLP-1 agonists. So we still have old drugs, and we have the potential for other combinations of drugs. So there's other drug combinations that have been marketed for obesity. So the naltrexone
has been dropped. Yeah,
naltrexone bupropion is one. And of course, bupropion or Wellbutrin is a drug that's also used for smoking cessation and for alcohol cessation. So for people that have habitual eating, things that are more addictive type of behaviors, that combination may be particularly good. And what hasn't been looked at, again, is these older drugs. So maybe we take phentermine topiramate and Wellbutrin and put them together in low doses, or using multiple different drugs, again, inexpensive ones, perhaps repackaging them so people don't have to take 4 pills or something. I think there's lots of opportunity out there to think creatively and to do things that aren't necessarily so cost prohibitive.
Absolutely. I want to now get into exercise. Both of us are big, I don't exercise as much as you do, but I try my best. But tell me a little bit about what happens to exercising and what are the changes in the heart which are expected.
Yeah. So the cardiac adaptations to exercise seem to be several. The one that's sort of most prominent, the heart tends to get a little bit larger, especially for people that do chronic exercise and particularly cardio type of exercise, as opposed to the static or weight training or resistance exercises. And that may be important because having a little bit larger heart then again it allows the heart to fill more and to pump more blood out, especially when people are going from rest to exertion. And as I mentioned, one of the problems in HF-PEF is that the heart is underfilled. It doesn't get enough blood into it. And so if you have a small heart, which a lot of these people do, then it's even harder to generate the cardiac output that's needed to perform vigorous physical exercise or even mild physical exercise. So trying to get the heart bigger is one of the goals, and exercise is one way to do that. Now, exercise is associated with other things. So resting heart rate is lower, blood pressure is lower, inflammation is lower, and weight may be lower. So there's lots of benefits to that. The other major benefit that we seem to see from exercise is adaptations in the skeletal muscle. So the changes that occur with skeletal muscle are even larger than the changes that occur in the heart when people exercise chronically and regularly. And when people talk about getting in shape, usually that is what happens. It's changes in skeletal muscle blood flow, the ability to extract oxygen, and perhaps most importantly, the ability to convert that oxygen into energy, the energy that's needed for muscular contraction. And those adaptations can occur fairly quickly. So people can start getting in shape within a week or two of starting to exercise. And most studies have been done show that there's not as much change in the heart as there is in the muscle. So, but the muscle is important. It's involved in metabolism. And, again, we can talk about this a little bit more, but one of the controversies in the weight loss field today is that when people lose weight with GLP-1 agonists or with bariatric surgery or perhaps even with lifestyle, is that they lose fat mass and they also lose muscle mass. And in most studies, about a third of the weight loss is actually losing muscle. And so that's not necessarily a good thing. And to combat that, there is a lot of interest in now trying to find pharmacologic approaches to maintain muscle mass or to even increase it. And there's some very, very interesting compounds that are being looked at either alone or in combination with GLP-1 agonists to try to help people lose fat but not lose muscle. And one thing that's being talked about a lot in this field today is the concern that if people lose fat and muscle when they take a GLP-1 and then they stop taking it and regain weight, the weight regain seems to be predominantly fat. And so now they actually have a more unhealthy body type than they had before. And this is sort of garnering a lot of discussion in the world. And so, again, one way to maybe combat that is to combine exercise with drugs. The people like the idea of, I don't have to exercise, I don't have to diet, I can just take this shot once a week or once a month or once every 2 months or whatever it's going to be as the new drugs come out. But that probably is not going to be a perfect solution.
So, let's talk about this. When we talk about exercise, everyone talks about cardio, and there's a general kind of a assumption cardio is good for the heart and strength training is not. So can you talk about aerobic exercises versus strength training and, what are the benefits of each?
So it's an area of lots of interest. The real research on this is fairly modest. There are a couple of trials that have looked at the two things, but they tend to be small studies where it's hard to tell. And one of the problems with these kind of trials is it's hard to get people to really do regular exercise, and it's very hard to get them to continue doing it after a trial ends. So, if we do a 3-month trial of cardio versus resistance exercise or HIIT training or the different kinds of things that people do, it's very difficult to know what the 1 year or 5 year or 10-year effects are because most people don't continue any of those things after. And the same is true with dietary interventions, by the way. But I think that my own take on this and my own belief is that we need both, and that the resistance training is helpful for maintaining muscle mass, which again is important for metabolism. Perhaps equally as important in this HF-PEF patient population, it turns out that there's a high rate of hospitalizations, but only about half of those are actually for heart failure. About half of them are for other things. And one of the common things is falls, and so especially in the elderly group, but again, in the group with severe obesity, where there's often severe deconditioning and perhaps balance issues and difficulty walking for other reasons, strength training probably helps us to prevent those things. And especially if we're focusing on leg strength and core muscle strength. And so avoiding tripping or being able to recover if your foot catches on something or, not falling, those things are very, very important. And the strength training, the resistance training is helpful. And in the HF-PEF field, we're sort of moving away from the idea of doing cardiac rehabilitation, as has traditionally been done for people that have a heart attack or something, and moving more towards a physical therapy-based intervention that may include some cardio, but includes strength and balance training as part of the what we do to try to help keep people healthier, keep them out of the hospital. So, I personally do both. I ride my bike a lot, but I go to the gym and do weightlifting at least several times a week. And I think especially as we age, that it becomes increasingly important.
Yeah, it's almost serendipitous, right? We tell our patients with HFpEF, as we said earlier, it's a huff puff. You're huffing and puffing, and we ask them to go walk more or bike more, and they're just unable to do so. I mean, how is there a protocol you follow to try to, help them increase their time, with either walking or, what do you advise them? How can they get started?
Yeah. So, I explain to people, and they get this, that typically over time, over years, weight goes up. They get more short of breath. They become more sedentary. The heart becomes involved. They get this thing, and there's a downhill spiral. But it can be reversed. And if we can start to even get a little bit of weight off and get people exercising very gradually, maybe we can make them feel better enough that then they can exercise a little bit more. And now you start to send that spiral back the other direction. And the better people feel, the more they do, the more weight comes off, the better their heart gets, the better their skeletal muscle gets. And so it is a reversible process, but it's a slow, painful start. But I think everybody knows that right. If you let yourself get out of shape, if you don't exercise for a month or two because you're traveling or you're sick or you hurt your knee or whatever it is, and you try to start up again, it's terrible, right? And so we
It's
lose
kind of
this.
almost frustrating, right? That you build it up and it just takes 2 weeks of not doing anything, and you're like, oh my God, why does this have to be so difficult? And if it's difficult for people with not that many chronic diseases, how much
Yes.
more harder it is for them.
It's much, much harder. But we do know that it can be done. And there have been some pretty good studies of it. And we've shown that people can improve their fitness levels pretty significantly in a period of 3 to 6 months. And then the key is trying to sustain it. And so, and that's where I think if you can combine weight loss and exercise, again, if you're pulling a smaller load, if you take off that big backpack, it's much easier to walk, and you're doing the exercise to improve the fitness, then you can sort of get double mileage out of it. But yes, it's hard. And everyone tells me they can't do it. And they also say, I can't lose weight because I can't do anything. But the reality is that they can. And we have seen it. We did a study here where we did a sort of intensive lifestyle intervention study, and we saw that people were able to lose, and they all had documented HFpEF.
Mhm.
And they lost about 7 kilograms, which is on the average 15 pounds. Some people lost more than that, And it was enough. It was associated with a very substantial increase in exercise capacity, as measured by the 6-minute walk test. So, people can do it. And I tell most of my patients to just start off, just walk. And you don't have to walk fast. You don't have to walk hard. You should walk fast enough that it's difficult to carry on a conversation. You should have to take a breath every 2 to 3 words. You don't really want to be gasping for air. You don't want to be miserably uncomfortable, because people won't continue to do it. So if it's enjoyable, people will do it more. And I advise people to find a partner, to find some way to make it fun. And so, spouse, a friend, whatever it is. And that once you start doing it, it can become habitual. And the good news is that bad habits are hard to break, and so are good habits. So if you develop good habits, and you miss a day of exercise, you miss it, you feel bad. And so that's the point that you want to get to, where you don't want to miss it because you like doing it. And so, and I tell people that the plan is to very, very gradually ramp up to the point where you're doing 45 minutes a day, at least 5 days a week. And the goal should be to do it every day, and realizing that there's usually going to be a day or two where you can't because life gets in the way. But if you set a goal of doing 3 days a week and then you miss one, it's not enough to do anything. So, I really do believe that you have to try to plan on doing it pretty much every single day.
I kind of try to tell my patients, think of it as brushing your teeth. You rarely go more than you don't skip brushing your teeth. Even if you don't do it twice a day, you definitely do it at least once a day, and you wouldn't go out without brushing your teeth. So you have to somehow, associate brushing your teeth. You're going to brush your teeth and then exercise, so that you have some sort of an association and a habit loop creation or something like that. And I mean, as you said, you aim for the moon and fall at the stars. That's okay. But you aim for, oh, I'm just going to go here. Then you really fall back. You aim for 5 days, then you end up with 3 to 4 days. And, that's at least some place to be. Then aim for 3 days and just do 1 day a week or something like that.
Right. I think most, the old adage was that 3 days a week, 20 minutes was enough. And I really don't think that that's the case. But on the other hand, going from something, or from nothing to something, actually gives you a bigger increment than, someone like me who, let's say I exercise 2 hours a day. If I go to 2.5 hours a day, I actually get very little additional benefit from that. So going from 0 to 20 minutes relatively gives you a lot of improvement.
All right, Sheldon, how much time should we be spending with exercise? What is a good amount?
It's a very good question. I think no one knows the exact answer. I think my own belief is that for the most part, more is better. And I think there are very few people that actually do too much. It is possible to do too much, like anything, right? And anything that we think as a good thing, potentially we can overdo it. So too much oxygen, too much water, too many carrots, and anything can be bad for us if we really overdo it. But for the most part, I think it's a very small subset of people that actually have to worry about that. And so, when we look at some of these studies of the super athletes, the Olympic athletes and the Tour de France bike riders and so forth, almost all of those studies suggest that there are marked increases in longevity in those people who are able to maintain very high levels of exercise throughout their life.
But I also want to know, what's the least minimum I can do to get the most benefit,
Right.
the sweet spot of exercise. Because
Yeah.
we all, you know that busy lives, career, kids, you're
Yeah.
pulled in million different directions. So
Right.
what's the maximum benefit? What's the minimum dose with the maximum benefit?
Yeah. So, any exercise gives you benefit. And, as we were talking about earlier, going from nothing to something gives you a huge benefit. And going from a, medium amount to a higher amount, you still get benefit, but it drops off. And then going from a high amount to a really high amount, there's actually very little additional benefit. So, if you look at 10 Tour de France riders and the guys that want to, exercise 7 hours a day as opposed to 6 hours a day. Does that help them win a race? Maybe, but they win the race by, 3 seconds something. So, going from nothing to something is certainly the goal for most of the population here. So, what's the ideal amount? What's achievable by most people? And again, my advice to most people is to shoot for 45 minutes a day of moderate level exercise, a minimum of 5 days a week. I think sprinkling in some different stuff, some resistance training along with that is I think if everybody did that we would have huge health benefits associated with it, and that people would see the things that we think of as being good: reductions in blood pressure, reductions in stress, better sleep, better metabolism. All of those things would accompany it. And I think you can do that amount, especially if it's walking or some relatively gentle exercise, without having a big risk of getting injured, of having a knee problem or foot problem or hip problem or back problem. And those are the things that plague people. And so as good as running is, I don't really advise it for most of my patients, because I feel like people get injured and then they stop, and then that's the end of everything. And so, as you age, injury is really there's two things that are the enemies of exercise. One is injury, and two is boredom. So if you can overcome those two things, and the importance is maintaining it right throughout your lifetime, and it becomes almost more important as you get older. But in order to do it when you're older, it helps to have done it when you're younger as well, so that it's easier to maintain than it is to gain in fitness. So
I have such a. So go ahead. Sorry, I didn't mean to interrupt.
My advice to most people is to have realistic goals, and to do something that you like, and to do it in sort of moderate levels, and do it regularly, and that there's nothing wrong with stopping to smell the roses along the way. So if you're out for a walk or a bike ride or a run or whatever it is you do, feeling too compulsive about it, it perhaps takes away some of the pleasure and the enjoyment. And I read stuff in some of my sports magazines, especially the cycling stuff, and people harken back to their childhood and the freedom that they got from being on a bicycle, and the joy of just being out and riding around. And it wasn't done for exercise; it was done for happiness. And so, if we can sort of maintain a little bit of that childhood attitude, that perhaps we have a better chance of continuing to do it.
So, a couple of things. You were talking about, they should be breathless. Every second, 2 words, they should be breathless. There's been this advent of devices, like, all these watches and heart rate monitors, etc. And I sometimes feel the joy of exercise is taken away by the minutia of, is my heart rate there? Am I within the zone? Am I in this zone? And you just get muddled down, and you're too close to the tree and you miss the forest. So are you a believer of these devices? Do you follow them? If you do, what parameters do you set for yourself?
I personally do not. I don't watch my heart rate while I exercise, but I would say if it helps you, if it's a motivator for you, then do it. If it's not, then I don't think it's something that one has to do or one has to have. And I think it's pretty easy to tell when you're working hard and when you're not working hard, and you can tell when you're pushing it. And as I've said, if you have an exercise partner, and if you can talk easily while you're doing it, then you're probably not going hard enough. And if you're gasping for air, you're probably going a little bit harder than you need to go, because again, if it's uncomfortable, people tend to not continue doing it. And so I do sort of believe that maybe having one day a week where you push harder, and you go for that does allow people to develop more fitness. But you don't need to do that every day. And then the other days can just be, enjoyable. But it shouldn't be easy to talk. So, and I know people that do monitor their steps and compete with their family and do stuff, and that's a big motivator for them. So I don't discourage it, but I don't push it either.
So another, you talked about 45 minutes, 5 days a week. I'm a personal weekend warrior. I can, because Saturday, Sunday are my freer days, and I tend to do, 2 hours on Saturday and Sunday, and maybe 30 minutes on the bike other days whenever I can, and something like that. Does that make a difference, like every day versus clubbing it? And, does that make a difference?
Um, I don't know that it may be the cumulative hours that you spend doing it that actually matters. But I do think that the people that only do the weekend warrior thing are a lot more likely to get some kind of an injury. I feel like if you don't do anything for 5 days and you're still young, but when you get to be my age, if you try to do that, I feel like a lot of people end up with their knee starts hurting after a while from, if you're pushing 2 hours, 2 days a week, and then you don't do anything or don't do very much the rest of the time. So I think that the very steady, not having big changes, and it's pretty clear that that's when people get a tendonitis or something is when they suddenly try to ramp up and they say, oh, I'm gonna run that 10K race in a month, and all of a sudden they increase their mileage, and it's always when people have some kind of a flare up of an overuse syndrome. So I try not to do that if I can, but I understand that again, that's how life is. I do quite a bit more on weekends than I do during the week as well. But
Yeah, it's I am like, I kind of call myself an anti-athlete, because every time I try to run, I end up with some sort of an injury. And after maybe 7 or 8 times trying to run, I've given up on running right now. And biking has become my way of getting cardio in. But strength training is what truly I feel like, I think maybe the instant gratification of being an interventional cardiologist, work out and you feel your muscles and those kind of a things. So I think that's what, as you said, I think to each their own, but consistency clearly is the key. I want to, marathoners in general, like my first heart attack was a patient who had come for one of the Charleston marathons, and at the half marathon point stopped, and was having an MI, and I had to send him for urgent bypass, had a left main thrombus and things like that. I mean, what do you think about, increased incidence of sudden cardiac death or pro-inflammatory state, the calcium scores? Let's start with calcium scores, and then we'll move to sudden cardiac death. What do you think? What happens to inflammation, and what happens to coronary calcium in marathoners? Let's start with them.
so coronary calcium is a way to look at hardening of the arteries. It's a form of atherosclerosis, and the sclerosis part of atherosclerosis means the calcium that deposits in the walls of the vessels. So calcification is a response to inflammation and injury, but it's a healing response. So it's not good to have calcium in your vessels because it's a marker of having disease. On the other hand, it's probably not the calcified plaque that causes the problems. It's the non-calcified or so-called soft plaque or lipid-rich plaque that usually causes MIs. But the reality is we have both. So we can use the calcium as a way to assess for the presence and the amount of atherosclerosis that someone has. So people were surprised a number of years ago when the first studies came out looking at calcium scores in people that were athletic, and particularly those that did higher intensity or longer things like marathon running. And they were surprised to find that those people had more coronary calcium. So the subsequent studies, several have actually shown that is the case, that most of them have confirmed that finding. And yet they have also shown that there is a lower incidence of myocardial infarction or cardiac events than would be expected for that amount of calcium. So the interpretation has been that it doesn't prevent us from getting atherosclerosis, but that perhaps more of it is healed and or stable. And interestingly, the same finding has actually been seen when people start taking statins, is that their coronary calcium score goes up. And it's thought that that's probably related to more healing and not necessarily worsening of atherosclerosis. So one of the paradoxes of exercise is that during the time when people are exercising, there is an increased risk of heart attack, arrhythmias, sudden cardiac death, etc. But during the other 23 hours of the day, there's a lower risk. And so, you take on that risk with an expected payback. And so, modulating the risk by perhaps not overdoing it, or in people that are at high risk of cardiac events, knowing it ahead of time and fixing them. So the sudden cardiac death in young people is typically due to congenital or genetic kind of heart diseases. And over the age of 35, most sudden deaths that occur are due to coronary disease. Now, again, not too surprisingly. It is much, much, much more common in men than in women. And again, coronary disease is twice as prevalent at any age group in men than women. So that's probably part of the explanation. There may be other explanations as well. And it may be that, men try harder, feel more macho, push themselves harder. And interestingly, most sort of sudden cardiac events that happen during races happen in the end of the race of the last half mile of the marathon, when people are trying to sprint and trying to do it is when that occurs. Typically not so much at the beginning. So again, that perhaps gives us some insight into some of the things that happen. So yes, there is some risk of exercising, but that's probably mitigated to become less of a long-term risk because of the benefits that come from all the things that are there when we're no longer exercising.
I think some of the time is like, when we're exercising, especially weekend warriors like me, we try to push ourselves a little bit more, and you kind of get competitive, and you're watching a video, or you're seeing somebody else do it, and you're like, oh, I can do this. That's a attainable goal. And you don't realize that person's lifestyle could be completely different from yours. And that person may have the time to exercise 4 hours a day, unlike you, who just comes, once in a while, or whose exercise capacity is way less. So we get kind of completely caught on by the competition. I can never do any of the group classes, because whenever I'm doing a group class, I'm competing with somebody else, and invariably I get injured. And then I realize, okay, these are my limitations, and therefore I have to kind of reconcile my limitations and do my best within that. So, and if that's happening for me in a small group class, I can imagine when you're running a race, how much more competitive a marathoner can get. What do you think about smoking and diastolic heart failure with preserved ejection fraction? How does it play into it? Smoking, when I talk about smoking, I'm just not talking about cigarette smoking. I'm also talking about vaping, which is now, oh, it's just vapor. It's not kind of, what are your thoughts about how that's affecting our population right now?
That's not really my area of expertise. I guess the question is, what is it in tobacco or tobacco-like products or things that's detrimental to us? And, in the past, we always thought that it was the tar and the stuff in the smoke itself, and perhaps not as much the nicotine that was the problem. I see lots of articles today, and people say, "Oh, the vaping is bad," and so forth. And so I don't know which component. I don't think vaping gives you lung cancer like cigarettes do, but there does seem to be some other adverse effects of it. And I don't know what kind of doses that people get from that of nicotine as compared to what they would get from a cigarette. I'm guessing that it's probably a fairly high, rapid dose. And I presume there's some people that are probably doing it a lot. But the answer is I don't know that I have seen anything published on the link between vaping and HF-PEF. It's probably a new enough phenomenon. And I think probably largely in young people that are at lower risk for HF-PEF. So I don't know that there's anything that's been established there. I could imagine that if there are surges in blood pressure associated with it, or heart rate, that could potentially be detrimental. So, but obviously, smoking to me is the opposite of exercise. Everything that's good about exercise is bad about smoking, and vice versa. And there's no athlete that's a real athlete that smokes. And so they're just two things that are so different and so antithetical to each other that I think that it's hard to think of them in sort of the same person. Uh, so clearly people need to not smoke. That's an I wouldn't say an easy thing, but it's something that's within our control. And is that a disease? I mean, it's an addiction, obviously, but that is something that people do have control over, and that certainly can and should be dealt with.
So, there's one thing we never talked about, and we talked about heart failure with preserved ejection fraction, how obesity and exercise, obesity is a positive predictor, and exercise makes you feel better. Apart from that, what other pharmacological therapies are available for our patients?
With HF-PEF specifically?
Yes. Mm-hmm.
So the mainstay right now, there's sort of two classes of drugs that have reasonable data behind them. One are drugs called mineralocorticoid receptor antagonists, or MRAs. The classic one is a drug called spironolactone. And the data on Spiro are a little bit mixed, but I think most people believe that it's effective. So spironolactone is a mild diuretic. It not as strong as some other ones. It lowers blood pressure. It may have anti-fibrotic properties, and we talked earlier about fibrosis being the thing that we think is sort of an underlying cause of HF-PEF. But it has several adverse effects that make it difficult to use. And so fortunately, there are a bunch of new MRAs that are coming out that seem to have much better pharmacologic properties, that rather than causing renal dysfunction, actually are renal protective, ones that do not seem to cause any hyperkalemia or gynecomastia. These drugs are extremely promising, and I'm sure that they are going to become a mainstay of therapy. Again, unfortunately, like most new drugs, they're harder to get. But I have little doubt that finerenone and some of these other drugs that are being developed are going to become a mainstay of HF-PEF therapy. The other class of drugs that's gotten a lot of attention is the SGLT2 inhibitors. As you know, these are drugs that were developed for diabetes. They promote sodium and glucose or sugar excretion in the urine. And they found that in some of the early diabetes trials that there was a reduction in heart failure events. And so began being tested in heart failure patients, including those without diabetes. And so those drugs have gained a lot of prominence, and they're being widely incorporated today. There's some interesting stuff about SGLT2s, as to how much the major effect that has been seen is a reduction in heart failure hospitalizations. Less clear whether there's really an improvement in survival in HF, and less of an improvement in symptoms or 6-minute walk distance or natriuretic peptide levels than what one might expect for the amount of improvement in heart failure hospitalization. So there's some questions surrounding all that, but nonetheless, it's become considered to be a class 1 indication. So SGLT2s and MRAs are the main drugs that we use, and then of course we try to treat other conditions. We try to fix hypertension if it's present. We try to fix diabetes if it's present. We try to treat sleep apnea when that's present. And so we're working on all of those things are probably important because they're all risk factors for HF-PEF.
Okay, sounds good. So Sheldon, let me time out here. Are there any other aspects of or questions you feel like we should be discussing which we haven't discussed?
I'm probably going to go in about 5 minutes or so. But I think the only thing is if we want to talk a little bit about bariatric surgery.
Okay, I don't think so. We don't
Okay.
want. So actually, if you got 5 more minutes, then I want to end with so-called a rapid fire. I'm just going
Okay.
to give you a couple of choices just to make it fun. Okay,
Yeah.
so let me
Okay.
get it back. So Sheldon, we're coming towards the end of our time here. So I just to make it a little fun, I'm going to throw some rapid fire questions, and you give me your options. Okay. You're served two plates. One is a low carb plate. One is a low fat plate. Which one is your choice?
Low fat.
Okay. All right. If you have to read a book, are you going to read the actual book or are you going to listen to the book?
I like listening.
Okay. If you have to go to a destination, car drive, or do you like to take a flight?
Oh boy, that's a tough one. Obviously, depends how far it is, but I do pretty much hate airplanes and airports these days. So I guess I would drive if I can.
Okay, so you kind of answered this, but I'll ask you again. Beautiful day by the ocean. You're going to bike or you're going to run?
Oh, I mean, today I pretty much only bike because I sort of used up my joints.
Okay. And how about, are you a paddleboarder or are you a kayaker?
Um, I do some of both. I was a whitewater kayaker for many years, but today actually I kiteboard or kite surf. That's sort of my water sport
Oh,
of
wow.
choice.
You took it to a new level now, kiteboard and kite surfing. Okay.
Yeah, so that's the tougher question is if I have the choice between kiting and biking, what do I do? And on the best of all possible days, I do both.
Okay. Sheldon, thank you so much. I have learned so much with this conversation. It's always a pleasure to talk to you. Thanks for taking the time, and I look forward